talk will be Dr. Kalpana Narendran, who still is my good friend, but nowadays I have stopped operating on for Squint. You will know after that why I stopped operating on for Squint. Kalpana.
After my talk or
After your talk.
okay, sir. So that.
Disagreement doesn't mean we are not friends. We are still friends.
Okay, thank you. So, good afternoon, everybody. Thank you. Like sir was mentioning about running away from neuro-ophthalmology, the next, as postgraduates, we run away is strabismus. But it is, as a practicing pediatric ophthalmologist, I can say that it is very easy to deal with children. And strabismus, if you go in a methodical way, it is definitely a very easy specialty. So, when you talk about strabismus, you have to first fix the goals of strabismus examination. So, first thing will be to establish the cause of strabismus. So, what is the reason for strabismus in this patient? And then there is a condition called pseudostrabismus, which we'll be discussing. Then the etiology, whether it is congenital or acquired, and then to rule out any restrictive pathology, because squint can occur because of many reasons. And most importantly is you have to assess the binocular, motor and the sensory status of the patient. Measure the angle of deviation, because that will give you an idea of how much to correct and how much to operate. And if there is an underlying amblyopia, diagnose the amblyopia, treat it first, and then proceed with the correction of strabismus. So history is very, very important. We all know for anything, the history is the foundation stone for making correct diagnosis, and a detailed patient history is the baseline for dealing with the strabismus patient. So in the history, what would you ask? One is the onset of strabismus. Is a child born with strabismus or it is an acquired strabismus? Because certain acquired strabismus, like if it's a third nerve palsy or a sixth nerve palsy, third nerve especially, which is a daytime emergency patient, because you never know, that might be aneurysm, patient would need immediate imaging. So that is very important, the onset. The second thing is and also in the onset, we've had patients presenting with an acute sixth nerve palsy will present as a esotropia in a child. I'm sharing my personal experience. This child, Shwati from Tirupur, I remember very well, came with the esotropia. Parents said she's got it for the past 6 months. And we did see her, and everything was normal when we saw her. But later on, it was a internal hydrocephalus. So that was presenting a sixth nerve palsy. She had to have a shunt. And I lost the patient follow-up, but bumped into them later to know the history. So any acute esotropias, have an imaging done and get a detailed history. And then the character of strabismus, because some of these strabismus can present later in life, or initially they would be intermittent, latent, intermittent, and then become constant. So the character of the squint is very important. And also to know that if it is precipitated after an episode of illness. Mostly the intermittent exotropias can sometimes be precipitated, or viral illnesses can present as sixth nerve palsy. And sometimes the other, superior oblique, fourth nerve palsies or nystagmus can present with a face turn or a head tilt. Again, more detailed history, you have to ask chief complaints, deviation of eye, spectacle wear, age of gestation, because prematurity can associate with presenting with strabismus. Family history, very important, because strabismus can run in families, especially certain syndromes like Duane's interaction syndrome can run in families, especially in women and more in the left eye. And then diplopia, if it's acquired strabismus, they can present with diplopia. And any history of patching, because amblyopia, the modality of treatment main is patching. And then delayed visual maturation, sometimes children with the cerebral palsy or other hypoxic encephalopathies can present with strabismus. And asthenopia, and any previous history of surgery, and any abnormal eye movements. So it's such a detailed history. And this is also very important. As strabismologists, we always talk as a fact test, the photo album test. Because you see this picture here, this boy at the age of 4 years presented with an esotropia. He was corrected at the age of 10 years, remained orthophoric, and later at 24 years, he presented with the consecutive exotropia. What was ESO of the left eye? It's become an exo. So this is very important. And also head turn. The head tilt, sometimes we pick up with photograph. This photograph, doctor, see all my pictures, I have my head like this. or somebody would have noticed and said. So this is a very important test in practice of strabismus. Then past history, if the child has already been treated by somebody, is there a history of patching, history of spectacle wear because accommodative esotropias, or even sometimes intermittent extremes or even constant extremes can be associated with myopia. Then the type of strabismus and blowout fractures. We're talking about restrictive pathology like blowout fracture, thyroids can present with a picture of strabismus, and any history of previous surgery because detachment surgeries, glaucoma implants, cataract surgeries, your superior rectus bridal suture can sometimes injure and cause strabismus. So probe into the history and detail history. And this is a set of instruments. Strabismus is a very simple practice. You don't need any high-tech investment to do strabismus surgery. You just need a good cover, a good target, and a good set of prism bars. These are loose prisms. These are horizontal prisms. These are the targets. And then we will show you the covers. But there are high-tech, like you have the Synopta 4, then you need a hair screen. The Synopta 4 is not really in use now. And then the hair screen, of course, check for diplopia. And these are all very simple. Just check the depth of perception. We're talking about the sensory status of the patient. So you need to check the stereopsis, binocular single vision, and the depth perception. So these are the RAF ruler. So not a big investment for a strabismus practice. Then coming to the physical examination, it's very important to observe the patient. As the patient walks in, the teaching is you observe the patient. Also in neuro-ophthalmology, they say you can find out the field defect. You can make out as the patient walks in, we can say whether it is a glaucomatis or it is retinitis pigmentosa or it is a cortical infarct. So as the patient walks in, you observe the patient. One is to look for any face turn or head tilt. The other one is to see the IQ of the patient. Sometimes these children are delayed, but the parents will deny that the child is delayed. So always assess the patient, which is very important. Visual acuity estimation also is the next important test. Sensorial evaluation, movements of the eye, measurement of deviation, and then all the special tests which I'll be talking about, cycloplegic refraction, and definitely a fundus evaluation. Again, a story to share here. Maybe I'll talk later in the fundus examination. A very healthy looking, share it now before I forget, a very healthy parent with a child, a chubby, beautiful child came in with esotropia and then turned out to be retinoblastoma in one eye. So it's very important to have the fundus evaluation done in all your strabismus patients, a detailed fundus evaluation. So talking about the apparent squints, this is a patient where you have a prominent epicathal float with a flat nasal bridge can present as a pseudoesotropia. So always keep in mind that not all patients who present is true strabismus. Always keep in mind about pseudostrabismus. And pseudoexotropias, mainly because of positive angle kappa, they have a wide interpupillary distance, a telecanthus, which can present as a pseudostrabismus. And this is what I was talking about. You have a pointer here. Okay, this is you can see this child presented with a small head tilt, and there is a facial asymmetry you see on the left side. So this is what is the observation for. So the observation is very important because you need to see the, maybe I should play the video again. Can you play the video again if you can? See the facial asymmetry on that side? I don't know, it's not working. Okay, this side is a facial asymmetry. And always this question comes, does a child cooperate? Invariably, if you treat them in a nice way, and when you examine a child, what is more important is to get faith from the parents. The parents should be convinced. So never touch the child. Always, because sometimes children don't like the touch when you go and grab them. So that is very important to get the cooperation from the child. So patient's visual behavior, check for the eye movements, look for the ocular alignment, and head and face posture, like already mentioned, and milestones and IQ is very, very important. Then coming to motor evaluation, you will do careful measurements of the angle of deviation, and which is very, very crucial in planning your surgery. Another point is, if the child is very low, then how would you know that the child is seeing well is by looking at the fixation. The fixation is the monoocular and binocular fixation. In monoocular fixation, you occlude one eye and look for the point of fixation. If it's central, steady, maintained. If the reflex is central in the pupil, if it is steady and if it is maintained, it indicates that the child has good vision in that eye. If there is a drift, I'll talk about it in interpretation. So again, binocular fixation, you have to estimate the degree of preference of fixation. Again, alternating squints, dominant eyes. So all that is for binocular fixation. So this is again the interpretation. If the fixation immediately goes to the preferred eye, it indicates that there is a strong fixation of the preferred eye and there is probably an amblyopia in the deviated eye. So this is what the interpretation would be for the fixation. So strong fixation alternating. If the deviation, then think of an underlying amblyopia or some fundus pathology. Right. Coming to the measurement of ocular deviation, which is very, very, very important in a strabismus examination, there are two tests. One is a light reflex test and the other is a cover test. In the right reflex, we have three tests: the Hirschberg's test, the Krimsky's, and the Bruckner's. So this is a Hirschberg's. You throw a light 14 inches away and look for the reflex. You can see very well here. This reflex is centered and this is an alternating esotropia. This reflex is in the pupillary margin. And this, based on this, you can say if it is in the pupillary margin, it's 15 degrees. If it is in the edge of the limb cornea, it's 30 degrees. Above that, it's 45. So that also give you an idea of the angle of deviation. So this is the Hirschberg's corneal right reflex test. And looking at the time, and the Bruckner's test. Again, this in our population might be a little difficult, but in Western countries, because of the lighter iris, you can then altered red reflex will give you an idea. See, altered red reflex, there is a cataract here. So it could be a tumor, it could be a strabismus, it could be an anisometropia or some retinal pathology. So that is one thing. And then the Krimsky's test is a prism reflex test or a prism reflection test where you use the prisms to move the corneal reflection, the deviating eye. So this boy here is a modified Krimsky's test. Suppose the eye is very densely amblyopic, that you cannot fix a target. So you put the target, the prisms of increasing strength over the normal eye and try to get the pupillary reflex in center. So this is the angle of deviation. So this is the modified Krimsky's test. When one eye is densely amblyopic or with poor vision or a sensory deviation, so this would be an ideal way to test the angle of deviation. Then cover test, you have three types of cover tests: the cover, uncover, the alternate cover test, and the prism bar cover test, which is helpful to measure the prism in diopters. So for a good cover test, you need certain prerequisites. One is a full optical correction, and then you maintain the distance, keep the head in primary position, choose the ideal fixation target. And for children, you choose a doll or something. For adults, you choose something else. And proper prism placement, proper occlusion. And very importantly, you need the attention and cooperation of the patient. So this is a cover, uncover test, mainly to differentiate. This is a child with the intermittent exotropia. You can see very well that, see, she's deviating. So the cover, uncover test will help you to differentiate between a phoria and a tropia. You have to break the fusion. So you see now, it gets the fusion broken and she deviates. So this is the cover, uncover test. Then second is the alternate cover test. It measures both the manifest and the latent deviation. So you dissociate the eyes for maximum deviation and then you do the measurement of the prisms. So this is the alternate cover test and this is the prism cover test. So this will give you the diopters of prism, how much you need. So you place the prism, I have to, one more, okay. So this is how you can see the child, placing the prism on the normal eye, and then this is how you hold it. I'm just showing the prism, the diopters. Loose prisms are more comfortable. So this is how you, and never stack two horizontal prisms. You can stack one horizontal and one vertical. So that is one thing you should keep in mind. So I'm not for want of time. And then simultaneous prism cover test. And this is how the prism cover test values will be depicted. And then this is prism adaptation test. When you're not very sure about this, you can do a prism adaptation where you can put Fresnel prisms to get the right amount of deviation, especially when the patient is very cosmetically, if she's very particular, then this is important. Then pattern deviation, always look for oblique muscle dysfunction. You can see inferior oblique deviation, overaction here for A and a V pattern. This is a boy with a V pattern deviation because all this will help in good results, post-surgically. And movements, you have the bilateral movements, versions or conjugate, the uniocular ductions and the distrugate versions. Again, I'm not going to the details. Cycloplegic refraction, fundus examination is a must. and it is not complete with the equiplegic refraction fundus evaluation. And always treat the amblyopia. Sensory tests, it is always better to have all these tests done. I'm not going to the details. Stereopsis. Then special tests, especially in restrictive strabismus or two, I may take just 20 seconds more. Forced action test, especially, when there is a muscle palsy, you want to rule out restriction, whether it is paralytic or restrictive. This will be a good test. A forced action test can be done in the office. You make the patient lie down and then try to pull and see if there is a restrictive pathology. Then the fourth generation test, another test where even in the palsied muscle, if there is some amount of function in the muscle. So if there is a fourth generation test is positive, then you would go and operate on that muscle. So that is fourth generation test. Saccadic velocities, again, to find out the muscle function. If there is a float, then it is not good. If there is a movement, especially in sixth nerve palsy, then you can, tackle with that muscle. So this, for conclusion, strabismus evaluation is not a very complicated procedure, but learn it methodically and keep all the tips which I spoke in mind. With practice, anybody can get better and very less investment. And I would recommend students here to take up pediatric ophthalmology, because in India, that is the population which is going to go up. So thank you for the opportunity.